today on Saga of retained Mops, Swabs and foreign body. Can it be prevented? And the purpose of today's talk would be, and that is very important, is to rekindle the awareness of the phenomenon of this condition called gossipy boomer and to highlight the implications and stress prevention that happens as soon as the case is detected. Now, this is called gossipy boomer, textiloma. Maybe, these are the various terms coined for the surgical mops or swabs that are left inside. Now, this is broadly retained foreign object and is the technical term used for surgical complications resulting from foreign materials, such as a sponge, accidentally that is left inside a patient's body. Now, this term is derived from the word gossypium, which literally means cotton wool or cotton. And the suffix oma means a growth or a tumor. Again, textiloma is derived from the word textile. And when you come and talk about the incidence, as Dr. Raj very beautifully highlighted, that the incidence is once in 3,000 to 5,000 abdominal operations. And mostly they are discovered in the abdomen, left behind. There was a study which was conducted, and there they found out the incidence to be 1 in 3,000 to 5,000. The incidence may vary in separate, different hospitals, and the incidence of retained foreign bodies like scissors and other surgical instruments is 0.01% to 0.001%, of which gossipy boma, that is the retained sponges, makes up to 80% of the total cases. What are the causes? The causes can be human. The causes can be environmental. Human, like if there is a communication failure with your team, there is cross-cultural surgeon to nurse failure, the gender-related male to female, hierarchical failure wherein from the captain to the crew, from the surgeon to the OT team. If there is a problem of level of education, training and experience, that may lead to this incidence. If there is noise in the OT, there are various distractions, cross conversations going on, frequent traffic in and out of the operation theater, or if there is sudden unplanned change in the surgery, then these may, be the cause. On top of it, if the surgeon is extremely tired, or if the surgeon has, just opened and left the surgery and another team comes and closes, and probably the exhaustion of the OT team can be, again, one of the reasons. What are the items retained? They can be surgical instruments, sponges, towels, suture needles, or accessory items. The location most frequently that has been seen is in the thoracic cavity, pleural cavity, pericardial cavity, but most commonly the abdominal cavity or deep in the pelvis. What is the pathophysiology? We all know that cotton is an inert material and mostly it does not stimulate any, strong biochemical reaction except formation of adhesions, granuloma, just to contain the foreign body that has been retained. Now, there are two types of major reactions that happen. That is, number one, an exudative acute inflammatory reaction with formation of an abscess in close proximity to the retained sponge. This will basically occur in the early post-operative period, and it may involve a secondary bacterial contamination, which may increase the intensity of this, inflammation that is happening ongoing. The second form of reaction that may happen is a aseptic fibrinous response, which contains the tissue, the foreign body in the form of encapsulation and formation of a granuloma. Now, how do these patients present? The presentation once you see the, the case scenarios that are being presented by our presenters now, they are variable. In all of them, they had different presentations. Very, very interesting cases we have lined up, and each one of them had a different and variable presentation. In some cases, there is a retained surgical sponge, which may be discovered mostly accidentally during a radiographic examination or during an unrelated surgical procedure. Or patient may present with a mass or abdominal pain, or more commonly as an incidental finding on a routine post-operative radiograph. Now, sponges which are initially placed in the chest or abdomen can, they may remain there, have an intense granuloma formation, or they can erode through the skin or into the GI tract, creating a fistula or intestinal obstruction. And that may appear as, the symptoms that I just highlighted, appearing in a bowel movement, causing hematuria, causing, bleeding in the defecation. So they may be detected by these presentations, and a colonoscopy or endoscopy may be required. What are the symptoms if they happen at all? The commonest symptoms are a palpable mass, pain, vomiting, weight loss, diarrhea, abdominal distension, or maybe cramps. Now, the complications can be an abscess development, adhesion, obstruction, fistula, peritonitis, erosion of the urinary or GI tissues, leading on to obstructive symptoms, or migration of the sponge into the lumen of GI system. How do you work up these patients? The first and foremost is a high index of suspicion, and then you work them up by imaging modalities, because these symptoms are usually non-specific and may appear years after surgery. Diagnosis usually comes from imaging studies, and a very important point, and that is a very high index of suspicion. Nowadays, these gauzes that are being manufactured, they have a radio-opaque thread, which can be easily identified on the radiograph, but this is not the case in all the OTs or in all the countries. You just look at this, here you can see this thread, which is coiled up here in the, abdomen near the sacrum. This is how the commonest presentation may happen in a plain radiograph. If you look at the ultrasound, in the ultrasound, it may appear as a well-defined mass with a very bright internal echogenic structure with a strong posterior acoustic shadow. In a CT scan, it may have a spongiform appearance, looks like a sponge with gas bubbles inside it, a low density mass with a thin enhancing capsule, and the surrounded, there is a thin calcification rim, around the architecture of the surgical sponge. Now, the most important differential diagnosis will be abscess and hematoma, and you may not be able to discern gossipoboma from a hematoma or abscess on a plain CT scan. So you may require a three-dimensional CT scan, which may give you a clearer, less ambiguous depiction of the object. In the MRI, you will get a well-defined mass with a fibrous capsule, which will exhibit, number one, low signal intensity on T1 weighted images and a high signal intensity on T2 weighted images. How do you manage? Now, that depends on the location. Patient should be offered removal of these retained surgical sponges once they are recognized. It is very important that you counsel the patient and offer this, that probably the pus that is coming or the infection which is not healing and the diagnostic modality that you have used is giving you a high index of suspicion. Offer this to the patient. In cases where patient is asymptomatic and sponge is detected by chance, surgical removal should be offered after the patient has been informed about the possible complication or possible retention of a sponge. Now, these RSSs are usually removed by open surgery, and my dear seniors and friends, here we are gathered today to understand the art of counseling these patients. Now, in selected cases, minimally invasive techniques like laparoscopy or endoscopy may be used, and endoscopy will be useful when this sponge has migrated within the lumen of a hollow organ, which can be accessed by endoscopy. Otherwise, it is very difficult to remove because of the dense adhesions. Sometimes laparoscopy can be useful when you know that you will be able to remove it laparoscopically. Otherwise, it comes out in bits and pieces, and some bits may still be left behind, and the patient's symptoms may not completely ameliorate. Hence, mostly open surgeries are performed. Now, coming to the very important aspect, and that is the crux of the whole thing, that it should not happen because it is considered a gross negligence. The prevention. Preventing retained surgical sponge is far more important than treating it. To prevent this condition, sponges are counted by hand before and after surgeries. Now, this method was codified into recommended guidelines in the 70s by the Association of Perioperative Registered Nurses. Now, the other guidelines have corroborated to the recommendations that has been highlighted by AORN. And these agencies are American College of Surgeons and the Joint Commission for Prevention of Retained Surgical Instruments. This is a surgery that was performed today in my hospital. This is a hemorrhoid surgery. In my hospital, the policy is that the sponges which are used and unused, you can see a thin thread of, these are radiopaque threads. We all are using, I'm sure we all are using these sponges now. And this was a hemorrhoid surgery, hence only the blood loss is so minimal. But all these sponges are put on the floor on a sheet and they are counted. All these small gauze pieces, again, these gauze pieces also have a very thin thread, which is radiopaque, because they are on the major OT table. So they are also there, and these are counted items. They are also put on that sheet and counted loudly. Coming to a brief history, why this thing came into being was that these sponge counts began in 1901, the needle counts began in 76, the instrument counts began in 80s, and accessory items started getting counted in the early 80s. The separate counts are recommended before any baseline at identifying manufacturing packaging errors. When are added to the field, again separate counts. Change of a scrub person or circulator and runner, again do a separate count. And do a separate count before closure of a cavity within a cavity. For example, when we are closing the uterus, it is inside the abdominal cavity. So first, once you are closing the uterus, count. Again, when you are closing the abdominal cavity, again check your counts. When wound closure begins and when there is skin closure, again, the counting is done aloud, and it is always, given to the surgeon and to the operating team that the counts are complete. Accurate counting of all surgical sponges during a procedure should be the priority, and this is most important. Any unnecessary activity and distractions during that time has to be minimized during that counting process to allow the scrub person and the circulator to focus on the counting tasks. The scrub person is putting the counts on the floor onto the sheet, and the circulator is counting and speaking it aloud. The scrub person should maintain awareness of the location of all these soft goods like sponges, the towels, the textiles, and all the instruments on the sterile field should, during the course of the procedure are counted and spoken aloud. It is the scrub person's responsibility, number one, to verify the integrity and completeness of the sponges when they are counted. Number two, to confirm that these instruments or devices that are returned from the operative sites are intact, and also speak up aloud when a discrepancy occurs. The needle is not found. Again, they won't let you close the abdomen. If you have experienced nurses, they won't let you close the abdomen unless they have, found the lost needle. This is the way the, OT table is designed. Again, this was just a picture taken in the morning for that hemorrhoid surgery. This is not an abdominal surgery. So all the counters are, all the, objects are placed at the designated sites. And these sites are known to the scrub nurse. The sponges, the loose gauze pieces, again, are counted aloud, and they are kept at the designated places. The surgeon and surgical first assistant should be aware of all the soft goods, all the instruments, all the sharps that are used in the surgical wound during the course of the procedure. The surgeon does not perform the count, but should facilitate the count process by communicating the placement of these surgical items in the wound to the perioperative team for notation. For example, in our hospital, we have a whiteboard. In Fortis Hospital, in Max, again, they have a whiteboard wherein all the counts are noted and they are put on the board. Acknowledging the awareness of the start of the count process, removing all the unneeded soft goods. Jo nahi chahiye, they are to be removed, and they should not be there in that site where, on the OT table where all the goods are kept. And all the instruments which are not needed, if you need them, they can be ordered again if surgeon can wait for it. And Perform a methodologically wound exploration when closing counts are initiated. Accounting for and communicating about surgical items in the surgical field, and notifying the scrub person and circulator about the surgical items that are returned to the surgical field after the count. And when the surgical team is changing, again, the whole thing, whatever process I have just enumerated here, has to be repeated so that the next surgical team takes over and knows about all the processes and all the soft objects and instruments that are there. The change in the team can be the change in the scrub nurse or change in the operating team. Now, it is very important for the anesthesia care providers to maintain situational awareness and engage in safe practices, because they are the ones who are the sutradhar and who are the jasus of your OT, They know each and everything in and out. So they should support prevention of retained surgical instruments. They should be the ones who should alert, and they should kind of, give awareness to the team that probably something is amiss. Situational awareness is a process of recognizing a threat and taking steps to avoid that threat. They should not use counted items. Usually they are in the habit, Doctor Sahab, ek gauze piece de dijiye. So, for the wiping the mouth of the patient or whatever. So that should not be the practice. They should not use it. They should verify that throat packs, bite blocks, and other similar devices, they are removed from the oropharynx, and they should communicate it to the perioperative team when these items are inserted and removed. And the scrub nurse has to keep an idea, or the circulating nurse has to keep an idea that the anesthetist has put something in the oropharynx or in the cavity somewhere in the body, in the bite blocks or in the throat packs. So that has to be removed before the patient is returned to the HDU or to the ward. Prevention of RSS is of key importance to avoid not only morbidity and mortality, but also the medico-legal consequences, and the cost of these medico-legal consequences can be really significant, because it can lead to increased hospital stay, may harm the patient, and definitely can lead to a litigation. The damages awarded vary markedly according to the circumstances, the injury, and the state country in which the cases has been tried, and the psychological trauma to the team and the nurse can be absolutely tremendous, and the negative publicity for the surgical care provider can be very, very significant. So, friends, the emerging technologies are very many. We have not used many of them. The physical counting can be facilitated. First of all, the most important is the basic physical technologies. They have to be the physical counting. That is the most important thing. The new technologies, they are being developed so that the efficiency is increased and the accuracy of counting can be improved, can be brought into the, OTs where there are many surgeries going on at the same time. They can be barcode and radio frequency identification technology. They have been incorporated in certain setups. The radio frequency identification system detects the sponges, and the sponge, they have those radio frequency sensors. The barcodes can be applied to all the sponges, and when you do electronic tagging of the surgical sponges, that involves a device that gives off a signal. And when you are sweeping the, this barcode detector, it makes a noise, and you will be able to detect a RSS. So, my dear friends, the take-home messages that we should prevent the retained surgical sponges. This is most important. A multidisciplinary approach may help to avoid these retained foreign objects. New technologies may help to reduce the incidence of retained foreign objects. There should be high index of suspicion of these objects in patients with past history of any surgery, and it should be included in the differential diagnosis of a soft tissue mass detected in a patient with a history of surgery. Please pay attention when counting the sponges. Your few seconds during that time can lessen the undue morbidity and mortality. Thank you very much. These are the references that were used in making these slides. Thank you.